Okay. Okay, hopefully I have this set up in a view on my screen that the people who are watching this as a recording can figure it out. So, type 1 diabetes, but first we are going to wrap up with what I didn't wrap up with on type 1, which was the answers to the questions. So, oh, we're not. Zoom is not letting me change that. Okay. So our questions. Short-acting insulin secretagogues are faster acting than sulfonylureas, so they may be especially effective to control what type of problem. So what kind of high blood sugars do we want a short-acting medication for? Somebody pick that out yesterday? Yes, so for postprandials, when you just want to cover that blood sugar rise after a meal, that's what those medications are especially good for. So they are the pair to short-acting insulins that you use for insulin boluses for the same thing. All right. So in patients with type 2 diabetes, glucose levels are adequately controlled with lifestyle changes or oral drugs, and insulin is added when they're up to 2 drugs and they're not under good control. So which medication is most effective combined with insulin for type 2? Metformin, which is also usually the first line. All right. Diagnosis is suggested by symptoms and signs and confirmed with which fasting test? Yep, fasting plasma glucose. So in most guides that you look at, they'll talk about the A1C, but usually you don't want to use that for actual diagnosis because that can fluctuate more and it can be inaccurate. So if you're just screening someone and they come back with an A1C at a level that you would think about diabetes, you want to confirm that usually with a fasting. All right, so if you have a patient who's over 45, has an impaired fasting plasma glucose, and they have some other risk factors, how often should they be screened? So if they're in that high risk or pre-diabetic group, how often should they be screened at this point? Every year. Yeah. Okay. So today we're going to talk about type 1, and we'll try to build in some comparison and contrast to review from type 2 as well. So our questions for today that we're going to think about: what causes an elevated fasting plasma glucose? So if your blood sugar is high first thing in the morning and you're trying to troubleshoot what causes that. Professor Jar told me that she thinks you all better know the answer to number 2. What is Kussmaul respiration? And 3, is family history a key risk factor for type 1 diabetes? We know it is for type 2. 4, especially in the pediatric population, when do you think about an insulin pump? What's the indication? All right. So type 1 diabetes, so this is completely absent insulin production. An autoimmune process is destroying the pancreatic beta cells in the vast majority of the cases. And then there's our favorite catch-all idiopathic, we don't know why. But In the vast majority, 95% of cases, this is autoimmune. Of all the cases of diabetes, this is a really small subgroup. It's about less than 10%, depending on what sources and numbers you look at. But in the under 20 age group, it's about 85% overall. This used to, once upon a time, be called juvenile diabetes until we figured out that it's not just kids that get it. So it got renamed. There's two peaks of ages where this tends to pop up. So it's typically in the pre-kindergarten group before age 5, and then again when kids are going through puberty. And how exactly this beta cell destruction comes about, we know that there may be some underlying gene abnormalities. We know that it could be some autoantigens, and it's even been possibly linked to things like viral infections triggering this. So there's a lot of theories, but not a lot of proof. Okay. So for our people who are listening to this, Bria was saying that your brother got whooping cough and then developed type 1. So had the pertussis vaccine, still got whooping cough. At what age was he? So in that adolescent trigger age already, 13 or 14, and then developed type 1. Yeah, so there definitely are kind of enough stories of people getting Epstein-Barr virus is another one that it's kind of linked to. But they haven't been able to actually test and prove the process, but they see the link. All right. So about 1.25 million people in the US have type 1. And it's kind of interesting that in different, whether it's environmental or ethnic backgrounds, the incidence can change. So in the US, it's about 1 in 300, but in Northern Europe and Scandinavia, it's much higher, and in China and South America, it's much lower. And this, I just wanted to draw attention to. So this myth that still is out there that type 1 diabetes is juvenile diabetes. And it's become more untrue in both directions. So now there are people over the age of 20 that can get diagnosed with type 1. But also, if you look at the second half of those statistics, so in the certain groups in US children in the adolescent age group, you could just as easily be diagnosed with type 2 diabetes as type 1. Especially if you're in high-risk ethnic background groups like African American and Hispanic. So type 1 is no longer exclusively for kids, and kids don't exclusively get type 1. So symptoms, this should look really familiar. Polydipsia, polyuria, polyphagia, weight loss, weakness, fatigue, nighttime enuresis, blurry vision, predisposition to fungal and bacterial infections, poor wound healing. Those are the same as in type 2. But how we separate them out in our minds is typically type 2 is coming gradually over years, and type 1 more often has kind of a more acute onset or shorter duration of symptoms from the time that they start to when they present and get diagnosed. And the reason for that is most often because in type 2, you're having this gradual resistance to insulin building up, and that's a gradual process. Once in type 1, enough of those beta cells are getting destroyed and they're not making insulin, you don't have that long timeline to get to a point where tips and they can't compensate anymore. And then obesity with type 1 diabetes, it's not incompatible. You can have type 1 diabetics who are obese, but more often we think of type 1 diabetics as really losing weight and being lean when they're diagnosed. So that's another contrast. Okay, so physical exam, if they're caught early, type 1s, there's usually not a lot on exam because, again, they haven't had this long timeline to start building up complications. So in type 2, our exam findings were all related to complications of diabetes, eye changes, changes in the feet, changes in their neuro exam, infections. Type 1, they're typically getting found before they've had time to develop all those complications. And the one major exception is a lot of type 1s are going to present because they're in ketoacidosis. And we're going to talk more about that. So if they're presenting with that, then they're going to have signs of ketoacidosis, including too small respiration, dehydration, hypotension, and confusion. So what is too small respiration? Anybody remember? Oh, Professor Johnson. So really labored, prolonged breathing. And those two things should be pretty linked in your head. Too small respirations and DKA. Yeah. Yeah. Yeah, this is just really, yeah. Yep. Really labored, prolonged. So by the time they're getting that they're also, kind of usually getting into that altered mental status category. So ketoacidosis often is how these patients initially present, especially in kids. Can be triggered by infection or other environmental factors. We'll talk about that more. And they're rapidly becoming severely hyperglycemic, and they can't compensate. So diagnosis of type 1 diabetes. So the same tests that we talked about for type 2. Fasting plasma greater than 126. Someone who's really symptomatic, and you do a random glucose greater than 200. 2-hour test greater than 200. And then A1C greater than 6.5. But again, if you got that, you usually want to go back and confirm with one of those other tests. And if they aren't symptomatic and all you have is like a, especially, if they got a fasting test of 130, kind of right on the borderline, and they're not symptomatic, you'd want to repeat that and confirm it on another day. But if you had someone come in DKA, I don't know why you would only get an A1C, but if you only got that, you're probably going to diagnose them. Other things you would probably be doing, screening for ketones. And then if you're not sure, so if you had a 12-year-old and you're trying to decide if they're type 1 or type 2, there's not like a simple test to run. So some things that might be helpful, they might do a fasting insulin level, They might do a C-peptide level, and they might do some autoantibody tests, of which there's a ton of them. And this would typically be done by endocrinology. Other things that can help differentiate if you were trying to decide if someone was type 1 or type 2, or just how you think about those in general. So type 1, they're going to be completely insulin dependent. They're not making any insulin on their own anymore. Type 2, at least initially, usually is not. The age groups in general are pretty disparate. So you're thinking younger than 20 for type 1 typically, mid-40s or older typically for type 2, but with our population getting more sedentary obese, that's changing. You think more often about type 1 not being overweight, but that is also something that is changing. And type 2 is typically obese. Onset, again, I said type 1 is usually more acute and usually gradual in type 2. And type 1 is more often going to develop ketosis and less often going to have family history. So less than 15% usually have a first-degree relative who was also type 1 diabetic. So if there's some genetic reason that they're having this auto-destruction, then they might have a family history, but that's not the most common history. And then you're looking for the antibodies in type 1, but not usually in type 2. Is that fairly clear? Does that make sense to people? Okay. The treatment, pretty much insulin. And you will hear about and read about some patients, they present with this major ketoacidosis event, and then they get that corrected and they don't need insulin right away. So they may have what's called a honeymoon period, where their cells rebound enough when everything is corrected that they don't need insulin right away. But it's just, at that point, they know it's just a matter of time. It's going to happen. Could be days, weeks, months. Typically, I think the reading I saw, like 2 years is probably the max and very unusual. So some routine screening recommendations, and the main difference you're going to note between screening someone for type 1 and screening for someone for type 2 is there are a lot more things that in type 1 they don't need to be screened for annually right away, again, because it's often so early in their timeline that they haven't developed a lot of complications yet. So there are some things that they don't typically start screening for until they've had type 1 diabetes for about 5 years, like the retinal abnormalities. Usually aren't expecting them to develop renal problems until they've had it for about 5 years. And then the screening things look very similar after that initial period. And we'll get into more of that when we talk about complications of diabetes. And in general, the goals are a little bit looser for glycemic control in type 1 diabetic patients. Does anybody have an idea why that might be? Why would you let them have higher blood sugars than type 1s? So typically it's because they're at such a bigger risk for developing hypoglycemia that a lot of them it's safer to let them run a little bit high than to risk them having continuous lows. So we talked about in type 2 diabetics, generally we want them at 6.5 or less, unless they're either having difficulty with low blood sugars or it requires so many medications to control it, they're having some side effects. But with type 1, so I have a little caveat on there. 6.5 might be appropriate if you can get there without significant hypoglycemia. But for most patients, to try to keep their insulin adjusted to keep them at a safe level, to be that well controlled but not having hypoglycemia problems is unrealistic. So probably the real answer if you asked an endocrinologist is you want them controlled as best tight as you can without getting them hypoglycemic. But that's generally what the picture kind of looks like. All right. So why don't you take a couple minutes and think about the points that we've covered so far. So, etiology, how do the risk factors look different, and kind of that comparing and contrasting type 1 and type 2 and see if we can recall most of those. Okay. What's one key thing someone thinks that we should probably remember from type 1 so far? Insulin. Yes, they're going to need insulin. Which sounds like this is going to make treatment much easier, but unfortunately it's just really not. What else? $95 autoimmune. What percent of all diabetes? 10% or less? Yes, I'm sorry. Acute onset. So that timeline looks really different. Age group? More likely to be kids, 20 and under. More ketosis, which we're going to get into. Yes. Okay. All right. So therapeutic options. And there are going to be a couple things other than insulin, but for the majority, we're just talking about picking insulins here. And the traditional, at least starting, is usually a combination of a basal insulin, so a long-acting insulin that's controlling blood sugars at a baseline, and then rapid-acting bolus insulins, which are mimicking what your insulin release would be with meals. More often in type 1, this is being done with an insulin pump as opposed to multiple daily injections, and we're going to talk about who should get a pump. And then there's some adjunctive medications that are sometimes used. Pramlintide is one. So the development of insulin analogs, pumps, advances in home glucose monitoring are all things that have made the treatment in type 1 much more efficient and effective. But first we're going to talk about their insulin options. So if you're doing the basal bolus, so they're taking a long-acting insulin and then supplementing with boluses. TDD on this slide is total daily dose. So usually, at least initially, people get about half their insulin for the day as a basal and then the other half in boluses. So the insulin is controlling overnight and trying to control in between meals, where the boluses are to control their blood sugar rise after a meal. So they're short acting. So by looking at the pharmacokinetics of different insulins, you can see which ones are more appropriate for that basal dose. So you're looking for things with long duration of action like NPH. And then you're picking the short-acting ones for the boluses. So things like Spartine, Lispro. So those are the ones that you're giving before a meal. So in type 1, we usually, at least initially, calculate their total dose based on their weight, 0.4, 0.5 units per kilogram per day. And then we're going to split that up, half basal, half in boluses. You might need a higher range if they're obese and sedentary, or if they're going through growth spurts, adjust down. So we start there and then see how we're doing with control and adjust where we need to. That's just another picture of the different pharmacokinetics, which ones are the long-acting as opposed to the really short-acting ones. Some have these higher peaks and shorter duration. Some are a little bit, don't peak quite as high. That's the general picture we're looking for. So you have their basal dose going, and then we're covering meals. Sometimes insulin alone isn't enough to regulate glucose in someone who's not diabetic. There's multiple hormones involved. And so we're not fully recreating that control by only replacing insulin. So amylin is another deficiency that has a lot to do with blood sugar control. So that is another one that's targeted for replacement. This is the amylin analog, pramlintide. It works by promoting satiety, slows gastric emptying, and helps inhibit that postprandial glucagon. So subcutaneous infusion of insulin. So our body does it best. Secretes insulin when we eat a meal. It releases enough insulin to cover that meal. Takes care of our background insulin needs. That's what we're trying to mimic. So with a pump, you can set it to do a basal infusion and set boluses to mimic that. It's kind of the nice parts. So you can have different infusion rates for basal. You can even increase the infusion rate during mealtime and then have a set bolus on top of that if they need it. It can pre-calculate insulin boluses. It has an alarm, most of them do, to remind someone if that they haven't given a bolus that they need to, and then they can just download all that data. Some of them also integrate with continuous glucose monitoring, so that it gives that feedback if you're doing a good job of control. So different pumps have different features, but most of them have nice small increments for making changes. You can preset it with different insulin to carbohydrate ratios. You can set it to having different calculations for multiple basal rates. So you might have one rate for a day where they're being more sedentary. If you have a student athlete, you might have a different basal rate for their practice days or game days, things like that. Different rate for a sick day. So you can build a lot of those things in. They have some nice safety features to alarm if, like I said, they miss doses, if they are not infusing correctly. And then some nice tech for downloading all of that to home computers or ways you can print it out and bring it to the office. So patients who switch to this tend to have improvements in their A1Cs by about 0.5%. Overall, this group has mean A1Cs in about the 7.5, so where we want them. They tend to have less hypoglycemia and less variability than those who are doing multiple injections. And they don't tend to gain excessive weight like some patients do when they're on insulin injections. And because of that, most patients have a higher level of satisfaction with it. When I was looking at this slide, this is from the American College of Endocrinology. So they strongly recommend it for anyone with severe hypoglycemia, anyone whose A1C is above target, anyone who's having fluctuating levels. That would be like almost all of them. It's good for young kids. It's good for those who are having John phenomenon, which we're going to talk about in a little bit, for athletes. So essentially, most pediatric patients are good candidates. The disadvantages, they have to remember to do the bolus. They also have to remember to do a bolus if they're doing an injection. So, you know, risk of ketonuria, ketoacidosis, probably the biggest, most realistic disadvantage is the expense. And I don't know that I've seen any studies that compare, like if you add up all the syringes and things over time, like at what point would you break even to a pump? But I think in practice, so how many type 1 patients have you seen shadowing in endocrine? Are any of them not on a pump that you can think of? So most of the kids and adolescents are on pumps. Yeah. And that might be that they didn't have pumps when they were diagnosed, and that's just what they're comfortable with now. So I have to say, I didn't see very many type 1 patients that weren't on a pump. Yeah. They are not cheap. But I think most insurances cover them pretty well now because they're so much better at control that, you know, the science has shown that we're preventing all of these higher risks of all of the complications if they're on a pump. So I think coverage is getting better. Mm-hmm. Mhm. Yeah, that is a huge problem for patients who, if their insurance will only cover a vial or a certain supply of insulin every 90 days, and then they're going to be traveling and not at their normal pharmacy, and so that could be a big problem. Okay, so patients who tend to be more successful on a pump tend to be those who have a good diabetic team behind them, have good insurance, and can either the patient themselves, or in the case of kids, if their family members have the capability to, can be a kind of complicated system, especially with pumps, of knowing what all of those alarms are, and when do you pick which basal rate, how do you calculation for the boluses. And not that it's necessarily any easier with the multiple injections, but it's a little more concrete for some people to think about that way. So. Some terms that they talk about with pumps that they don't talk about with injections. So insulin on board. So they got a bolus and that hasn't been completely absorbed. It's still coming down off of that peak. That's the insulin on board. And they talk about insulin stacking, which is when they're giving extra correction dose of insulin. They've tested their blood sugar, it's high. But there's still some insulin on board. So they try and make sure they're not going to overcorrect. They have to think about how much insulin do I still have left from that last bolus? When is that going to run out? And how much more insulin might I need to add? And then a correct sensitivity factor is correction based on an individual patient's data of how much a unit of insulin tends to reduce their own glucose. And that's something that's calculated looking at their logs and their data of how much insulin they take and then what their blood sugar change is. So smart pumps, they can have a bolus calculator, but patients still have to be checking their blood sugars. They still have to be able to understand trends. When I was looking at patients' blood sugars, it was always amazing to me when I'd see a patient who had logged that, the last 3 weeks, every day at 3 o'clock, they'd had to give themselves an extra dose of insulin because their blood sugar was high every day, but they hadn't recognized that maybe they should be correcting now their basal dose or something else instead of taking a correction every day at the same time. So they have to start watching for those trends over time. They have to be able to estimate their carbohydrate content because when they're doing boluses, it's based on how many carbohydrates they're planning to eat at that meal. They have to think about the lag time, and some of these calculations are very artificial because it's assuming that they're going to eat the same number of carbs for every breakfast, for every lunch, for every dinner, that they're going to have the same amount of exercise every day. And so the patients have to learn how to adjust to make up for those changes. Yeah. So yeah, typically all type 1 patients have endocrine involved, and they would certainly be involved with reviewing some of their numbers, but they might only be seeing their endocrinologist every 6 months or once a year. So their primary care provider might still, or their diabetes educator might still be the one that's looking at logs in between time and helping them pick out, wow, you seem to be having hypoglycemia most days at this time, or helping them pick out those trends. And you're doing that with type 2 patients as well. So it's something that you kind of get comfortable with over time. Okay, so this next sections, I don't want you to worry about as far as testing and all of that. This is kind of just what's up and coming in the science, and I want you to be like, have heard of it, but it's just kind of things that are happening. So continuous glucose monitoring, like this is one of the holy grails that they've been searching for a good way to do this for diabetics, to just be able to not have to poke their finger. How many have started doing that? Having to do that on a routine basis, 3-4 times a day, more often if you're sick or if you're adjusting your medications. So to be able to have a way to just have a continuous way to access that and just maybe push a button and get a readout and know what it is. So there are glucose monitors, professional continuous glucose monitors. The equipment is owned by the provider. And some patients can't see that data. Some can. Or it could be personally owned. So it's owned by the patient. And they can continuously see the data. And there's still a lot of debate. Ones that are out now, are they always accurate? What level of accuracy? Not that that's a question with checking your blood sugar either, but this is something that's really been worked on. We do know that the more they can know their blood sugar levels, the better people can control their diabetes, and reduces their hypoglycemia, helps them stay at targets. If they're doing it daily, if they're using it intermittently, so you tell them that they want to know what their postprandials are, what's going on at night, it can still be helpful. All right. So mostly they were recommending this for type 1 diabetics. You don't really see it a whole lot in type 2 unless they're on really insulin-dependent protocols and complicated protocols. They're starting to look at it for gestational diabetes or type 1 or type 2 women who become pregnant. They don't particularly call it out in this slide, but cost is another big issue here. And then the artificial pancreas. So closed loop artificial pancreas, so trying to link a continuous glucose monitoring device with an insulin pump and recreate that same system. So far, they haven't, in studies, shown a significant difference in outcomes. So it secretes insulin and glucagon, monitors blood sugar, runs on algorithms and controlled from your smartphone. And it does, it can change the bolus. You tell it what your meal is going to be, and it makes the decisions. So telling me you have a typical meal, I'm having a big meal, just a few bites, and it does the calculation. So hopefully this is the future where things are moving, but cost and technology is not quite there for most patients. Okay. So now these last two parts, I'm kind of getting into a little bit of complications, but I couldn't figure out how to talk about type 1 and not talk about hypoglycemia and DKA. It really felt like there'll be fewer complications to go over tomorrow, so just look at it that way. Hypoglycemia. This tends to happen more with older patients. Women tend to have more than men. African American patients tend to have it. The longer patients have diabetes, the more they tend to struggle with this. And once they're starting to have complications like neuropathies and renal impairment, that puts them at a higher risk for hypoglycemia. And it's kind of a self-perpetuating cycle, which we'll talk about. If they've had hypoglycemia, that increases their risk to have it again. Things that patients do that add to this is if they are skipping meals and if their overall control isn't great, that puts them at higher risk. In type 1, especially when you think of toddlers and preschoolers, kids are unpredictable. They don't eat what you put in front of them. They decide they didn't like it that day. They get really active playing. It's hard to predict how much insulin they're going to need. Imprecise administration of low doses of insulin. So you didn't give them quite the amount that you intended, especially if they're newly diagnosed and they're getting the actual injections. You know, how easy is it to hold a kid still multiple times a day to poke their finger and give them injections? Kids get sick a lot. That doesn't help. And they also can't tell you when they're starting to feel some of the early symptoms. Why do we worry about hypoglycemia? Puts them at risk for a lot of problems. So they get confused and irritable. They're more accident prone. They can fall more. The more they have hypoglycemia, the more they can develop future hypoglycemia, and they get unaware of the symptoms of it. It makes their diabetes harder to control, and they're at higher risk for cardiovascular complications. So when do they start having symptoms? So typically at about 70 or below, they will start to have mild symptoms. They might get anxious, sweaty, palpitations. They might be hungry. They might start to have some strange feelings like their fingertips or their lips are numb, having some paresthesias. As it increases, so if they're getting closer to the between 50 and 70 range, they might have more behavioral changes. They might be more emotional. They're confused. These are the patients that I would think of that when they're in that range, they might be kind of just wandering and they're trying to remember what they were going to get and they can't think of what got up to do. And severe is generally below 50, and that's when we're heading into the very altered mental status or unconscious range. And these people definitely typically can't correct it themselves. So treatment, if they are conscious and alert, we want them to quickly get their blood sugars back up in a safe range. So they want to have fruit juice, crackers, milk, glucose tablets. They have glucose gels that they can carry. Usually about 15 grams of carbohydrate is what they're trying to aim for. And then we want them to recheck their blood sugar after about 15 minutes and see where it's at. And this kind of becomes a loop. So they're feeling it. They check, they're below 70. They take their 15 grams of carbohydrate recheck. If they're still below 70, they're going to do it again, 15 more grams. If they're back up above 70, they move on to thinking about when their next scheduled meal or snack would be. And if it's going to be more than 2 hours, they need to at least have a snack now, something that's going to sustain them a little bit more so they don't fall. If they're way below 70, they're confused, unconscious, they need an injection. You're obviously not trying to shove crackers down the throat of someone who's got such mental status that they're not able to swallow. So some glucagon, and they need to go to the hospital. They also, if they do this loop more than 3 times, they should probably be going to the hospital. So if they're at 50, they take 15 grams of carbohydrate, they recheck. They're at 55, 15 grams of carbohydrate, they recheck. They're not getting back up there. Something's going on. They need to be seen. Okay, so why does this become such a trap? It feels crummy. So have any of you ever had a hypoglycemic episode? It's not just diabetics that get this. It feels crummy. And so, especially if they've had a bad low, they're going to tend to change behaviors to try to avoid having that again, which may mean that they start eating more, may mean that they start taking less insulin than they're supposed to. And so that's going to affect their overall glycemic control negatively, which we saw was one of the risk factors for developing lows again. So it can kind of fall into this pattern. Okay. So very specific low. This is called the Roji effect, or sometimes it's called dawn effect. And this is a low that they typically didn't know about. So overnight, your blood sugar is dropping. And when it's dropping, correcting it by sensing it and then eating, they rebound and they have a high. This one kicks in, rebounds. And so they get this high fasting blood sugar. So the question earlier, why do you have a high fasting? Well, it could be either. Either it's been rising all night long, or it's because you're having some lows and it pops back up. The way you figure out what it is so if you have a patient that's having highs in the morning and you're trying to decide which it is, is it running all night long, or did it climb and a little rebound back up in the morning? The way to figure that out is to check a 3 a.m. blood sugar. Okay. Hypoglycemic unawareness. Why do people start to have, can be very severe hypoglycemia and not have a lot of symptoms of it? This is because over time, if they've had a lot of frequent lows, their ability to set off your fight or flight response starts to get blunted. It could be because it's happening so rapidly that it doesn't have time to trigger symptoms. So if someone, for example, really gave themselves an incorrect dose and it really dropped their blood sugar so quickly that they may not have time to really develop symptoms of it. Over time, over years, as you're developing neuropathy, that can prevent you from having some of those symptoms. If you're really stressed or depressed, you may not be paying attention to that, or if you're not taking care of yourself in general. Alcohol can both blunt the ability to comprehend what's going on with your symptoms, and it can also blunt the symptoms themselves. A recent low, again, kind of blunts some of the symptoms, and certain medications can So if you're on a beta blocker, you're not going to get palpitations. That can block some of yours. And we worry about people who are unaware of lows because they're the ones that are going to end up going into DKA. So to make yourself more aware of your lows, you have to try to not have as many of them. So if they've had a low, we're going to tend to say either they need to increase their snacks, they need to decrease the insulin. Be careful the next few days so that they're not going to have a low again. We're going to have them checking more often and making changes before they get to that range. We're going to let their blood sugars be a little bit higher overall. And if this is a trend where we're seeing people are having recurrent lows, then we need to, have they changed something in their lifestyle that's causing that? They've become more active, they've lost weight, which are all great things, but it can be things that lead to lows if we haven't adjusted their medication to match that. All right. So what key things about hypoglycemia? All right. So what about severe? What numbers do we think about for that? 50. Yep. What do they look like? What are they presenting with lows? They're hangry. Way to sum it up. Palpitations, shaky, tremorous, irritable, confused. And we're trying to break that cycle. So we want to make adjustments so that they're not having recurrent lows and developing unawareness. Okay. Ketoacidosis, last thing we're going to do today. So most often you think about ketoacidosis in type 1 diabetics. Type 2 diabetics can get it. So they're developing hyperglycemia because they have absent insulin. They're starving their cells. The insulin can't move into the cell, and they're developing ketogenesis and acidosis, metabolic acidosis. And the hyperglycemia is causing osmotic diuresis. So they are getting volume depleted and they're losing all their electrolytes along with that volume. So they're getting hypoglycemic, they're getting dehydrated, they're getting ketotic, and they're getting metabolic acidosis. And this could be triggered by an infection. They are missing doses of their medication, probably the most common. So they aren't adhering to their regimen, or maybe they're depressed and they just aren't taking their medication. They had some kind of malfunction with their insulin pump and it's not giving them their insulin. They got ill and they didn't have a good plan in place or weren't following their plan. They had some major trigger like an MI, pancreatitis. They got started on steroids and didn't get adjusted with their other medications appropriately. And more recently, some patients who are on SGLT2 inhibitors that's been associated with more DKA. Okay. So they are thirsty. They're having polyuria, abdominal pain, nausea, vomiting, and they're weak, very weak. And the two kind of buzzwords that are associated with DKA are Kussmaul respirations and the fruity breath. This distinct smell their breath. Other things you might note, they might be a little hypothermic, they're tachycardic, and then any symptoms that you would see with severe dehydration. So hypotension, orthostasis, dry mucous membranes, not good skin turgor. All of those things that make you think of someone who's really dehydrated. Combine that with small respirations and the fruity bath, and you know they're diabetic, you're worried about this. Usually they're extremely hyperglycemic, more than 250. Could be lower if they have other complications going on. They have ketones. They have high levels of beta hydroxybutyrate. I can say it. They're going to have an anion gap, low arterial pH, and they're trying to compensate for their metabolic acidosis. So low PCO2. Criteria for diagnosing this, unfortunately, depend on who you ask. So the College of Endocrinologists have this group of criteria. Kind of focus on, the next slide is going to show the ADA criteria, but they do have some things in common. So low pH, ketones, high anion gap, and symptoms are pretty well agreed on. Endocrinologist College focuses on these levels of hydroxybutyrate, but the ADA doesn't really include that. And they focus more on a plasma glucose level, and the College of Endocrinologists don't feel like that's always helpful. You could have a lower blood sugar and still have it. But in common, the pH, the ketones, anion gap, and the mental status, I think that's pretty well agreed on. So these people can go into shock, they get hypokalemic. You could overcorrect, they could get hypoglycemic. You worry about cerebral edema as part of your immediate treatment is going to be fluid replacement, and if you're placing it too fast, they could get cerebral edema. They could develop renal failure, respiratory distress. I mean, these people are in trouble. They look sick. So management, if there was anything that they were taking that you think precipitated it, you're going to stop that immediately. You're going to start getting them fluid replaced, and then work on correcting the acidosis and the electrolyte problems. And then look for underlying causes that need to be treated as well. So this is someone that presented to the emergency room, or if they went down at home, they're getting shipped to the emergency room. If anyone ever showed up in an outpatient setting with this, you're getting them immediately to the hospital. Okay, so we'd prefer to prevent it than to treat it. We want patients to understand those symptoms and signs and things that are putting them at risk. So we want them to be checking their blood sugars more often, particularly if they're ill or post-surgery, things that could make them at higher risk for this. They need to know how to do urine testing. They need to know how to manage their insulin on sick days. And you need to address if there are patients that are not doing good self-cares because of other issues, that we address those as well. We're going to talk more about that with complications. All right. Questions about DKA? So I really want you to just kind of know key symptoms, the agreed on key findings, and what we need to do with them first. Get them to the hospital, get them fluid replaced, and start correcting electrolytes and the acidosis. Okay, let's go back to our questions. Elevated fasting plasma glucose. What causes it? So it could be hypoglycemia at night, it could be dawn effect, rebounding, or it could be that they were just hyperglycemic all night long. So that's when we do the 3 a.m. check to help us differentiate those. Kussmaul respirations, deep labored breathing. Is family history a key factor in type 1? No. Only 15% of them will have a family history of type 1. And which kids should get a pump? All of them with good insurance who can afford it. Yeah. That is all. So tomorrow, the very beginning of class, we're having a high school student with type 1 coming. So if you, as part of your reflection on today, think of some things that you might want to ask her about. I don't know how much really prepared she's coming in with, so we might need to have some thoughtful questions that we can ask her to help her tell her story. I think she's going to talk about how she got diagnosed and what that's been like for her. But if you have some questions that you'd like to know the answers to, or if you have family members and you wonder if their course was typical, then you could think about that. And then we're going to jump into the complications of diabetes, which a lot of that will be kind of review of other topics that we talked about. Diabetics could get this, so it'll be a nice way to go over some things that we've already heard, but thinking about it, especially in the light of diabetes. Any other questions? Okay, I asked a few of you earlier, so anatomy lecture. Which reminds me, I can stop this recording now.